Okay, well, ready to get started here. So good afternoon. I'm Allison Brashear, and I'm the Dean of the Jacob School of Medicine, Vice President for Health Sciences. And I want to welcome you to today's talk, Translating Addiction Science into Prevention and Treatment. Before I get started, I want to thank Dr. Jill Cizek, who is Associate Vice President for Research here at the Jacob School. She is part of the Vice President for Health Sciences group and has done an incredible job at putting this program together. So from prevention to early treatment and comprehensive treatment, recovery support, addiction science advancements, all of these are improving outcomes and fostering hope for individuals with addiction. The health sciences at the University at Buffalo are involved in cutting-edge research in addiction medicine, pain management, and contributing significant advancement to these fields. We're honored today to welcome Dr. Nora Volkow. She's the director of the National Institute on Drug Abuse, better known as NIDA, at the National Institutes of Health. And she's going to present here at the University at Buffalo on translating addiction science into prevention and treatment. A little background. NIDA is the world's largest funder of scientific research on all health aspects of drug use and addiction. And Dr. Volkow's pioneering work has been instrumental in demonstrating that drug addiction is a brain disorder. As a research psychiatrist, she's led groundbreaking studies, including using brain imaging to investigate how substance use affects brain's function. And her research has documented how changes in the dopamine system impact brain regions involved with reward and self-control in addiction. Additionally, she's made significant contributions to the neurobiology of obesity, ADHD, and aging. She graduated from the National University of Mexico in Mexico City, where she received the Robbins Award for the best medical student of her generation. She completed her psychiatry residency at New York University, earning a Laughlin Fellowship from the American College of Psychiatrists, one of the top 10 outstanding psychiatry residents in the United States. So awards as a medical student and a resident laid the groundwork for her amazing career. So I'm just going to pause and let everybody breathe in what I'm going to say. She has published nearly 1,000 peer-reviewed articles, 113 chapters, manuscripts, and articles, and edited the neuroscience of 21st century. She's edited 4 books on neuroscience and brain imaging for mental and substance use disorders. She has been recognized by many organizations. By Time magazine as one of the top 100 people who shape our world, by Newsweek as one of the top 20 people to watch, and by the Washingtonian magazine as one of the 100 most powerful women. She's been recognized by U.S. News and World Report as an Innovator of the Year, and by Fortune magazine as one of the 34 leaders who are changing healthcare. So I just wanted to say a little bit about UB. We've got a lot of visitors on our screen here. So as the Dean, it's just my pleasure to say that UB has been a national leader in addiction research and treatment. For over 50 years, the Clinical Research Institute has conducted groundbreaking research on substance use, misuse, addiction, and treatment. Our clinical training and addiction fellowship equips physicians with specialized treatments to treat substance disorder. UB and Josh Lynch, Dr. Lynch and his team have developed rapid treatment access. Started as Buffalo Matters, it's a UB-developed program that expedites access to care for long-term opioid use disorder, featuring initiatives as naloxone and the fentanyl test strip vending machines. So now Buffalo Matters became New York Matters, and now it's just Matters, and it's in multiple states and really helping patients every single day. We have an addiction studies minor that educates students on the complexity of addiction, and we have the pioneering research that is on addiction recovery and the neurological effects of prenatal alcohol. So UB is really proud to welcome Dr. Volkow here, and so I just would like everyone to join me in welcoming her and thanking her for bringing her valuable insights and advances into addiction science. Welcome, welcome to UB, and I'm going to turn it over to you, Dr. Volkow.
Thanks very much for that kind introduction. And I'm delighted to hear that the university has been a leader in promoting the use of medications for opioid use disorders and other strategies to address the overdose crisis. So I have more or less 45 minutes, and I have to actually, what I'm aiming to do is to give you a perspective of the actually why is it important and what are the opportunities that we have from science. So with that, let me share my slides. I'll need to know if you are seeing them. Hold on.
Yes, we are.
Okay. Do you see them?
Yep, perfect.
Okay, good. So I start by what is the nature of the problem? And I think that overall, certainly the numbers speak by themselves. And if you look at this is data that was just released from SAMHSA, basically for their survey documenting on a yearly basis the number of people that get exposed to drugs, the number of people that end up with a substance use disorder, and the number of people that receive treatments. And so I start by presenting this because overall, the use of substances is incredibly widespread in our country. And if you look at it to the left, which tells you the past month's substance use in people that are 20 years or older in the United States, you can see that 134 million people in the United States consume alcohol in the past month. And then the question follows, what other drugs actually are they consuming? And what is notable, and I think it's crucial that we pay attention to, is that the second one is tobacco products. And this is relevant because while we have seen a significant reduction in cigarette smoking, we're seeing alternative products that are being used either as tobacco or as delivery of nicotine, most notable nicotine vaping, for which we currently have in the United States close to 28 million people. But I also want to highlight how prominent the consumption of cannabis is in our country. And this prevalence of use of cannabis has been going up in individuals of that are 18 years of age or older. We're not seeing in the adolescents. And this reflects, in fact, clearly the legalizations across most of the states in the United States for either medical or recreational marijuana that has translated in a significant increase in the use of this substance by American citizens. So, what is it? How does this translate? One in two people have used alcohol past month, one in six have used a tobacco product, one in seven marijuana, and one in 10 are nicotine vaping, which actually comes to, if you look at tobacco and nicotine, you come to realize how prominent nicotine is in the consumption pattern in our country. Despite the fact that fortunately cigarette smoking at least has been going down quite dramatically. Now, taking drugs doesn't mean that you have an addiction problem, doesn't mean that you have a substance use disorder. And of course, the negative consequences of drugs are very much dependent on the doses that the person is exposed to, the frequency with which they take them, and extremely importantly, the age at which they initiate the use of drugs. So, the younger the person uses drugs, the greater the likelihood that they will transition from substance misuse or experimentation for whatever reason into an addictive phenotype, which is what we call substance use disorder of moderate or that is moderate or severe. So if we go to those numbers and ask the question, how many Americans, knowing that there are so many that get exposed to drugs, ultimately end up with a substance use disorder, which is when you have this compulsive pattern of drug consumptions that you cannot longer self-regulate, that has negative consequences. If we ask that questions, how many of the Americans fit that criteria? We see that actually the numbers are very high. 48.4 million people in the United States suffer from a substance use disorder, and this is from the past year. So it's basically a current substance use disorder. The most common substance use disorder, as you can see it over into the right, drug use disorder, including basically all of the drugs. But as a single drug, the drug that produces the most amount of problems and in substance use disorder is alcohol use disorder. 27.9 million people in the United States suffer from an alcohol use disorder. And second in ranking, and I actually, when I saw this data, which was just recently presented to me 1 month ago by SAMHSA, it just struck me and I cannot stop thinking about it. 20.6 million people in the United States fill diagnostic criteria for a cannabis use disorder. And this is something very, very challenging because cannabis use disorder can be very, very difficult to treat, and we don't currently have any medications. And these numbers are going up, the number of people that are having a cannabis use disorder, and are driving the prevalence overall of drug use disorders in our country. Other notable substance use disorder, opioid use disorder, important to know. We don't really know exactly how many people have an opioid use disorder, but the estimates of SAMHSA place it at 4.8 million people with an opioid use disorder, followed by stimulant use disorder, which is cocaine and methamphetamine. It is important to dwell on these two numbers because even though they are not certainly much lower than what we see for cannabis or alcohol, they have been driving the horrible overdose crisis that have plagued our country over the past 2 decades. So let's jump into it. What does the science tell us? And this is, of course, crucial because it's necessary to understand what is it that drugs do in our brain that actually can produce addiction, and why is it that people can take drugs and not become addicted and others do. So understanding that and being able to pinpoint that why is crucial for tailoring the interventions, both for prevention and for treatment. So what do we know? That yes, drugs are necessary. They change the brain and in ways that actually can produce these compulsive patterns and the loss of self-regulation that characterizes addiction. And we know that they are very strong biological factors. And we've known all along from heritability studies that addiction goes in family. And this has then been ascribed to the important role that genes may have on the vulnerability and risk for taking drugs. And ultimately, once you take drugs, to actually the vulnerability that you will become addicted to them. Because as I say, not everybody that gets exposed to drugs becomes addicted. We've also known for many decades of research by predominantly epidemiological studies that the environment is fundamental in determining the vulnerability of getting exposed to drugs, certainly, but also escalating into the transition into addiction. What we do not know, and it offers us the opportunity to actually, in terms of what we currently are doing in research, and we have the tools and accumulating the data to address that question. How is it that genes, why is it that genes, how do they influence the brain that in ways that make them a person more or less sensitive to their environment, so that when they get exposed to drugs or that facilitates their exposure to drugs, then that transitions into addiction. In other words, we are right now at the stage in science where we are able to look at the interactions with the different factors that in the past have been dealt of as isolated, understanding what the environment does, or the genes, or the development, which is another extremely important concept in the whole field of substance use risk and addiction. As I'm going to repeat, the younger you initiate drug taking, the more consequential it will have in terms of increasing your risk for addiction. Similarly, the more adverse an environment that person grows on, the younger they are, the greater the negative impact that they will have, not just for increasing the risk for substance use disorder, but also for increasing the risk of other mental illnesses, which by themselves also increase the risk for substance use disorder. So that and all of these permeates into two elements. One of it, the drug itself, what does it do? And the other one, what does it do to the brain in such a way that it changes your behavior? And then that has the downstream effects of all of that, the domino effects of that will ultimately to affect how your brain is stimulated or not by the environment that ensues when a person becomes addicted. So that's where we are with in the field of research for substance use disorder, and this research is targeted very specifically, not just for curiosity, which is a good thing to have, but also importantly, specifically to address how do we get that knowledge into prevention and treatment and ultimately recovery. So, what do we know? Lots of research has been done into trying to understand what are the genes that are involved in the vulnerability for addiction. And again, this has been a major investment of research in our portfolio. And as you know, the genome-wide association studies have actually enabled us to understand better. I mean, it's a strategy that is powerful. It's a powerful tool that actually, unfortunately, requires huge, vast numbers of samples in order to be able to identify what are the genes that have emerged as modulating your risk for substance use disorder. The largest ever study of GWAS was published relatively recently in 2023. It was done in more than 1 million subjects. And basically what it identifies is what other studies in smaller samples have already noted. This gigantic sample basically included people with different types of substance use disorders and evaluated two questions. Number one, are there specific genes associated with a particular substance use disorder? And second, are there common genes that actually connote the vulnerability of addictive phenotype, irrespective of actually what the drug a person is exposed to? And again, this is an important question that has plagued decades of research because investigators have determined, I mean, ultimately, the drug that a person consumes is very much reflects to a very strong extent those that are available. And that's why we have periods in times in the United States where the problem with is predominantly with cocaine, and then it is methamphetamine, and now we're living problems with opiates, and as I showed, problems with cannabis that reflects the availability, the accessibility. The same thing happens with nicotine. When nicotine did not exist, of course, nobody was addicted to it. But then when it became available, we see how it ramped up the number of people that were relevant, that were affected. So what do these studies on this polygenic, but these whole genome studies show? That the main weight, the main influence is a polygenic risk score, not for any particular addiction, but that addiction phenotype. That's what this study clearly shows, consistent with what others have identified. And there were 42 genes that were linked with higher risk, of which one, the FTO gene that has been associated to modulate, that has been linked with obesity, interestingly, and that also modulates the expression patterns of the dopamine D2 receptor gene, which has been one of the ones consistently linked with vulnerability for substance use disorder. And importantly, the one with the strongest weight is the phosphodiesterase 4B gene, which is an enzyme. The gene encodes for an enzyme that regulates the concentration of adenyl cyclase in the cells, in this case, highly expressed in the brain. So yes, the main factor is the risk for a phenotype of addiction. There are genes that are specific for specific substance use disorder, as can be expected with alcohol use disorder, opioid use disorder, cannabinoid use disorder, or tobacco dependence. But the effect, the weight of those genes and the contribution for those these specific disorders is much less than that of this polygenic risk score. And what is also notable out of this study, which is again driving how we think about these studies into the future, is the fact that they are not specific just uniquely for these genetic addiction risks, but they are comorbid. They are also increasing the risk of other mental illnesses, very notable ADHD, suicide attempt, major depressive disorder. So diseases that are both in the mood disorder category and in the extraversion component are frequently comorbid, as we know, and this could be in part adjudicated to the fact that they are common vulnerabilities as it relates to genetics. Well, what about the environment? So the environment also is not going to be specific. It's not like a particular environment is going to may make you vulnerable to one substance use disorder versus the other, unless, of course, the environmental factor is the availability or not of that particular substance. But the main factor that has been shown, again, by far the highest weight on influencing the risk of someone to develop a substance use disorder is the number of adverse childhood experience as individual encounters during their early years of life. There are multiple adverse childhood experiences that have been actually described as abuse, neglect, household dysfunction. And adverse childhood experiences, in many ways, are more or less likely to occur as a function of certain socioeconomic characteristics of a particular community. And so, for example, in communities with very low income, surrounded by high levels of violence, with very little opportunity for work or development, it is more likely that the children of those parents are subject to adverse childhood experiences. And the extent to which there are differences between the influence of the various types of adverse childhood experiences is something that is being investigated, but overall, it has a huge impact in general as it relates, as you can see in the figure to the right, showing the odds ratio for illicit drug use as a function of the number of adverse childhood experiences. This is an old study from 2003, but actually the findings hold consistently. This is the most consequential factor if you are to identify factors of risk for developing a substance use disorder. It can increase it close to tenfold if you have more than 5 or more adverse childhood experiences. So it's a key aspect. The aspect that we don't completely understand is why. What is it that these adverse childhood experiences are doing to the brain of the individual that is making them vulnerable to a substance use disorder and also, as I said, to other mental illnesses? This is just also to illustrate that another element that has been crucial for investigating all of these processes of risk relates to developmental stages. The early stages of life are the most consequential, as I mentioned at the beginning. And this slide actually shows that the brain is changing significantly. And most of the changes in the brain occur until you are in your early 20s. And then the brain continues to change after that until you are very, very old. But and these different curves reflect different metrics that relate to the brain structure. So, for example, this one here reflects to mean cortical thickness, which is the purple one with the dotted. So let's look for the white matter volumes. You see these ones here, over here. And you see that the trajectories are very, very different, but they're moving very, very rapidly. And in particular, my eyes go to this white matter structure because it's changing enormously from birth up to age 20, 24. And this is just structure. When you start to look at function, you come to realize that there are enormous amounts of changes occurring during childhood, adolescence, and in the transition. And it is exactly in these periods where you start to see the highest prevalence or for the incidence of the psychiatric diseases, including substance use disorder. So in general, substance use disorder uh, occurs most frequently between 18 and 30 years of age. But drug experimentation starts around adolescence, and that, as I say, is very relevant. And these are periods during which you also have the highest likelihood of seeing the expression of the emergence of psychiatric diseases, which again are highly, highly comorbid with substance use. So how do we take this information? Well, from the perspective of NIDA, in my brain, certainly it was a non-brainer to actually says we are right now at the stage because of the technologies in imaging, because of the access to computerized systems and databases that can be protected to develop the largest longitudinal study to investigate how the human brain develops and to ask that very specific question that actually basically led me and then to convince my fellow director from the Alcohol Institute, George Coop, to launch this study in 2015, which was started really for recruiting in 2016, the ABCD study, Adolescent Brain Development and Cognition. And in my brain, I know I've always known that yes, the development of the brain starts during fetal development, but I wanted to know and to address the question that was crucial and plaguing the whole psychiatry world and psychology world and policymakers of whether in fact the use of cannabis during adolescence increases your risk for schizophrenia. And this is important because you have seen how massively cannabis is being actually consumed across the United States. And it was crucial that we provide that information. And while there were a lot of epidemiological studies documenting worse educational outcomes and brain metrics in these teenagers as they grew into young adulthood when they consume cannabis in adolescence, the big confound was always how do you know that their brain was not already different and that made them more vulnerable to taking drugs. So considering and sort of saying, well, what is it that we need to do in order to be able to address that question? That's how the ABCD study was born, with the knowledge at the same time that actually it will be an incredible resource to first understand individual developmental brain trajectories in the human brain. So the study was started recruited in 2016, 12,000 children, close to 12,000 children, including 2,000 due of multiple births from ages 9 to 10. And we've been following them into early adulthood to assess just how the influence of individual, how the factors like drug exposures in pregnancy, drug exposures during adolescence affect their brains, and the presentation of mental illness or cognitive performance. And after sort of, it's actually 8 years, we're going into, well, it's 9 years because that started in 2016, 9 years, and 95% of the participants have been retained. The data is basically released on a yearly or not close to a yearly basis, open access for anyone in the world that's interested to take advantage of it. It evaluates not just brain imaging, various metrics of brain imaging, but it evaluates every 2 years that's done. But on a yearly basis, the investigators are evaluating cognitive performance, social networks, use of social media, health outcomes. We have, during the COVID pandemic, we actually also increased the sampling to understand how the change in social conditions of these children of school, the uncertainty, how that ultimately affected their brain. So it's a massive, extraordinary study. And you see there all of the sites that are part of the ABCD. And if you've never taken advantage of this database, I urge you to look into the sites and work on it because it has been an extraordinary source for knowledge creation. So what, for example, I'm going to pick up just a couple of things to taste your appetite, sort of like the question, does the use of drugs during pregnancy affect the brain of the newborn? Very important. It's our brains are ultimately part of make us who we are in interactions with our environment, right? But so, and this has been a very important question that has been mostly investigated for two substances, alcohol and tobacco. And there's no two ways around it. No one is questioning. It can have very, very deleterious effect. And I'm glad to hear that the University of Buffalo is actually is one of the areas of research to investigate the actions of alcohol in pregnancy in children and and later on in adulthood. But there's much less work with other substances. For example, there's very limited work. The work on cannabis exposure is limited to retrospective analysis. And while it is clear that cannabis consumptions lead to smaller waist size and prematurity, the extent to which it actually can produce uh, changes, morphological changes in the brain is unclear. Parents of children that were exposed to cannabis during pregnancy do report a variety of behavioral problems with these children, but it is again is more anecdotal report than very robust findings. And so for the same thing with overall, as I mentioned, to cannabis and other drugs like stimulants. So there is a major need. So this is an example. This is a study that came up of a paper that came up from the ABCD data set, where the mothers are evaluated for their consumption of drugs during pregnancy. Even though we are recruiting at age 9 to 10, the mothers and the father are evaluated. And then the investigators went ahead and looked at the cognitive abilities and the brain volumes of children that had been exposed to cannabis during pregnancy versus those that were not. This is important because note on the left square, there has been a 75% increase in past month cannabis use in pregnant women in the United States. So this is a number that is going up. And in part, I mean, some of these women are using it because it is being available as an anti-nausea medications during pregnancy. So what are the studies showing? That those that were exposed, for example, in terms of cognitive abilities, this is a test, the Littleman test. It's actually a test that requires, is basically evaluating visual spatial abilities of the child. You need to actually identify if the image is the same by showing different rotations. The little man has a briefcase and you need to understand whether it's the same or not. And you can see that overall, and it has two measurements at baseline and then 2 years later. As I say, this is a prospective study with imaging and evaluation regularly. And you can see that there is a significantly worse performance on this particular test in children that were exposed. And similarly, the measures of crystallized intelligence are lower. And the improvements that you see over the 2-year period are attenuated on those children that were exposed to cannabis. When you look at brain volumes, you also see, and I'm showing you two metrics, intracranial volumes and white matter volumes. And you see also significantly smaller volumes, intracranial volumes in those that were exposed. But the largest effect sizes are, in terms of differences, are seen in white matter volumes, which are actually the ones where you see the largest changes in terms of differences in these individuals that were exposed to cannabis in these children. So this is another study, but it's looking at it in a different way. It's looking at, does the time at which you get exposed to cannabis make a difference, which is of course very relevant because the development of the brain occurs throughout the various trimesters, and there are some trimesters where exposures may be more consequential. So what they did is they divided the women into those that were unexposed, the children from divided their depending on whether their mothers had been unexposed to cannabis, exposed before they knew they were pregnant. So it was a very limited time period when they were taking cannabis, or those exposed post knowledge. And here you have several measures: externalizing problems, attention problems, thought problems, social problems. And you can clearly see that the effects are much worse in those that were exposed post knowledge. There is a negative effect for those that were exposed just early on, but by far the most significant effect is the exposed post knowledge. And to the left is the association at baseline when they are 9 to 10 years old. And to the right is basically showing the same findings, but when these children are 11 to 12 years of age, just to indicate that the deficits are clearly actually persistent. And they have a significant increase on having problems with associated with mental illness and cognition. Of the mental illness, these problems, they are much more likely to have higher scores on externalizing factors. So that is with respect to how do you get drug exposures affect your brain if it's actually it's occurring during fetal development. But a key element too, and I said this is the most consequential factor that we know of, the social determinants of health that then are going to be impacting the likelihood and the risk of having adverse childhood experiences. So what is it that the ABCD has shown us about how these social determinants of health affect brain development? And I'm going to illustrate it with two findings. This is the first one actually that was reported 5 years ago by Marcia et al. That actually was trying to understand how lead ultimately affected cognition in children, in these children from the ABCD, and how it affected their brain volume. And what they showed, which was C4 cognition in the upper part, and for brain changes, cortical surface area or cortical volume in the lower part to the right, is that yes, being exposed to lead, which is actually in the x-axis showing increasing risk of lead exposure, is associated with lower, basically, regardless. So the three curves actually are divided based on the incomes of the family: children from high income, children from middle income, and children from low income. And then they plotted it as a function of the exposure to lead. And they showed that, yes, there is a significant negative effect on cognition and on the brain with the higher levels of lead exposure. But what was notable about this study is that the effect is only basically expressed in children from low income, whereas you don't see that association in those with high or middle income. So I show this study because it was the first one to guide that what the data from the ABCD studying is saying is, yes, it's absolutely clear that lead is not good for the brain development, but it's also indicating that there is an interaction, and the social economical deprivation is a factor that is enabling the negative toxic effects of lead exposure. Or alternatively, you could make the argument that the support that exists in families that have middle or high income can basically buffer potential negative effects of lead. And this is an important question that, of course, needs to be addressed mechanistically. This is another study from the ABCD. And since then, many studies have actually, in fact, corroborated that low income is one of the most consequential factors in determining cognitive performance in these children. And also in determining brain volume, cortical thickness, and functional brain activity. So it's not just structure, it's brain function. And in turn, it is important because overall it has been shown that it's also the main contributor by far of determining what had been in the past identified as differences between this group or that group based on categorization of races or ethnicity of other factors, that these are being underlined by differences in socioeconomical deprivation. And so this study is very powerful because it, again, uses the ABCD to actually show how important income is in outcomes, but they look at it differently from the policy perspective. And what they actually look is of all of the sites that are participating on the ABCD, they divided those sites where the children come from states with very high cost of living. For example, of course, New York and California, very high cost of living, versus the states, and those are in blue, versus the states where they have low cost of living, as can be the case of Tennessee or Alabama, which is much less expensive. But these states also, what they enter into the equation was whether those states provide cash support for the families or not. So if you're in a in a blue state, you can have a state that provides high levels of cash support, cash benefits like California, or not. A very high, expensive one, but it's not providing cash benefits. And the same with low cost. And then they look at brain volumes and internalize, in this case, internalizing problem scores, which is what I'm showing you here. And they show that if you are in a high income, basically family, you are sort of a child of a family that has the resources, it doesn't really matter whether you have or not cash benefits. And this is for the high cost of living. But on the other hand, if you do come from a high cost of living in a low income, then it makes a huge difference. And if you do not have the cash benefits, there are much greater number of these children have a much higher prevalence of internalizing problems than those also from states that are high cost of living, but for which actually ultimately there were cash benefits. So coming from a low income family can be mitigated by policies that can help those families thrive in such a way that you can then prevent some of the adverse effects that otherwise you will see in these children. And the same phenomena they actually report for the changes in hippocampal volumes. So social factors are very, very important. So then what other questions can you ask for the ABCD? And this is one of them that actually is looking at now that the children, they are now close to 17, 18 years of age, but the data as it relates to exposure to drugs actually is starting to emerge, because when you're very young, you don't take drugs. So in this particular study, they are looking at what are the factors that lead teenagers to start experimenting with drugs before they are 15 years of age. And what they actually show is that one of the most important factors that actually determines the risk has to do with the coexistence of mental illness. So externalizing factors, rule breaking, aggressive behavior. And we have known all along that that is the fact. That is one of the factors that contributes. But it's also identifies that the networks of those children, teenagers are actually crucial also in increasing the risk. On the other hand, if these teenagers perceive that there are negative consequences, then they are much less likely to take it. But among all of these, I want you to identify that number one risk factor over here is prenatal cannabis exposure. And the other one is parent with drug or alcohol problems, highlighting how, and this may relate to the issue of what the children is exposed to when they are growing up, not necessarily just the effects of the drug during fetal development. And because these children are now starting to take drugs, and this is a longitudinal study, we can ask that very important question that led to the deciding the power size of the ABCD study, which was, how do we ask that question? Does marijuana during adolescence increases your risk for mental illness? Does it affect the brain structure and function? So we can now go to the brains of these children. Well, now they are young adult, well, young, older adolescents, and those that are using substances at before age 15, and look backward and see when they were recruited at age 9 to 10, can we differentiate them from those that are not taking drugs? And this is a paper that was published in 2024 showing those results for two metrics, brain volumes and cortical thickness. And actually, this shows higher values in those that were actually taking in red, taking drugs before age 15, and in purple, lower values in those that did not. And what was remarkable and not necessarily predicted was that those children at age 9 to 10 that go on to take drugs when they are actually before 15 have larger brain volumes across multiple areas of the brain. And they also, on the other hand, have also a larger, more thicker cortical thickness in certain areas of the brain. But on the other one, you can see these areas here with significantly thinner cortices. And that's the superior prefrontal cortex, the medial prefrontal region, which are fundamental for self-regulation and could again underlie their highest risk that they actually may be taking drugs. But it is notable because what it's telling us in the past, these studies would have been interpreted to indicate that cannabis is responsible for the thinner cortices in these or older adolescents that actually are that consume marijuana, and therefore that drives the thinner cortical thickness. Whereas these studies are showing that no, that there are certain characteristics of the brain that appears to increase the risk of these teenagers consuming substances. And again, this is the first study of its kind from the ABCD, and it's just the beginning. But I welcome anyone in the audience to actually take advantage of it and to start to look at it. Right now, the data is deposited to investigate whether there are other characteristics that can lead one to predict who is at greater risk. So the ABCD has had a huge impact, and it's not just the publications. As of now, there's more than 1,300 publications. It has been used to actually these publications, the data, to basically help in guidelines across all of the world. So it has been very, very consequential. It has led to information of topics that are of extraordinary relevance, like, for example, how does sleep deprivation, that we now know is one of the problems that is occurring among adolescents in the United States, affects the brain, how the amount of screen use affects the brain and affects other behaviors. And ultimately, the other example that I'm putting them is how did the COVID pandemic affect the brain development. So it was so successful that 3 years ago, we launched, again, in partnership with other institutes at the NIH, led by NIDA, a study also that longitudinal for brain development, but initiated in infancy. So this study is recruiting pregnant women and then following up their children for up to 10 years. The goal is to recruit 7,000 children. As of now, July 2023, I presented the data yesterday, and we now have more than 4,000 participants enrolled. So that's 3,282. We are now at 4,000, with a very significant number of them reporting exposure to drugs during pregnancy. The data was released at the end of the spring 2025, and I encourage you, it's the largest database ever released on 1,500, which is what the data is releasing, brain images from infants, image at 1 month and 3 and 9 months. So along with all of the characterization of the mothers. So this is, again, will provide us the means to address that extremely important stage in life that determines risk for substance use, but also for mental illness and other medical conditions. So why is this important? Well, it's important because it can help us guide prevention interventions that are tailored. And so hopefully we can prevent people from developing a substance use disorder. But overall in science, I mean, you want to address everything with prevention, but unfortunately there are people that ultimately, even if you have very strong prevention, basically are going to develop the disease and are going to need treatment. So for us, in our portfolio, we're actually, of course, funding research to understand better how is it that we should be able to treat individuals with substance use disorder, and ultimately how to help them recover. So, is this a problem? Yes, it is a major problem. You saw the numbers that I showed you for the number of people with alcohol use disorder and cannabis use disorder and the other substance use disorders. How many of them are receiving treatment? Well, this is data from SAMHSA released, as I sort of basically 1 month ago. Less than 20% of individuals 12 or older receive any type of treatment for substance use disorder. So there's a huge gap. So the whole question is, of course, why this gap? There are multiple factors that are driving this gap, including the lack of providers for treatment, the lack of education of personnel that could take care of people. But there's also the whole issue that there are limited treatments for the management of substance use disorder. And so there is an urgency to develop better treatments or treatments. There are FDA medications for opioid use disorder, alcohol use disorder, and tobacco dependence, but they are none for cannabis use disorder, none for cocaine or methamphetamine use disorder, not to say inhalant use disorder. So yes, there is a massive need both in terms of expanding the workforce that can take care of people and implement the medications that are currently available that save lives, and to train healthcare personnel to be active in the screening and treatment, but also in the development of medications. But because my goal on this presentation is to whet your appetites of areas that are very exciting, I chose two examples for the research that we are asking investigators to actually expand. And one of them is the enormous potential that we can see in terms of, in general, of psychedelic drugs, which we have a very negative reputation, but they actually are fascinating from the pharmacological perspective, because these are drugs whose effects are not limited to the time that the drug is interacting with a receptor. In the case of the classical psychedelics, and when I speak about psychedelics, I'm speaking more than just the classical, but I have the example here of a classical psychedelics, which are the ones that are agonists at the serotonin 5-HT2A receptor. And perfect examples are DMT, psilocybin, LSD. But the same thing can be said with other psychedelic drugs like ibogaine or ketamine. That what it characterizes, which is fascinating, the effects of these drugs is the effects. There is the intoxication effect when the drug binds to the receptor that basically is relatively short-lived. For LSD, it can be 5 or 6 hours, but it's relatively short-lived. But on the other hand, both in animals and clinical studies show that the effects are long-lasting. And in animal studies, where you can do invasive assessment of the effects of these drugs, researchers have been documented now for many years that they basically promote neuritic growth, spine density, synaptogenesis. They modify the structure of the brain in ways that facilitates certain pathways that in a way appear to be influenced by the setting and the conditions at which the drug is administered. So that's why I actually highlighted the psychedelic drugs, because it is really modifying the way that we have looked at pharmacology from the perspective. You have to be constantly in treatment to actually, can we use these drugs to promote neuroplasticity? And as we understand what are the systems that are affected, to tailor promoting that neuroplasticity. And by the way, because psychedelic drugs are not per se, and neuroplasticity is not something that is specific for addiction, but it basically prevails. Basically, many of the brain disorders, certainly many of the ones of psychiatric diseases, psychedelics as well as pain, which also connotes neuroplastic changes in the brain, chronic pain. How to use them again to be able to tailor interventions for the treatment, in our case at NIDA, for substance use disorder, in our case at NIDA, well, if we are using them for comorbid conditions, substance use disorder with mental illness, like post-traumatic stress disorder, like depression, comorbid diseases like with pain. And the other one that I want to highlight is that of the glucagon-like peptide receptor agonist medications that are being basically developed for initially diabetes and then for obesity. And NIDA has been funding studies now for more than a decade in preclinical studies, predominantly in rodents, but also in non-human primates. And what these investigators have been showing, whether it is nicotine or it is tobacco or it is alcohol, GLP agonist medications reduce the rewarding effects of these drugs. They reduce the self-administration of these drugs in animal models of addiction, and they also prevent relapse. So I'm taking two of these studies, one of them basically, but I'm using a recent one. One was published in 2021 showing that liraglutide, which is an old first generation GLP medication, reduced heroin self-administration. You can see it. The green one is the liraglutide. And then the lower one is basically a study that has not yet been published from the laboratory of Leandro Vendruscolo and George Koob that's evaluating the effects of semaglutide, a second generation GLP drug that's much more effective than liraglutide for obesity and for diabetes, significantly reducing fentanyl self-administration in these animals. So in the animal literature, yes, it works. What do we know clinically? Also significant reductions in the use of substances. There are two studies that actually have been done in relatively large samples of individuals with alcohol use disorder where semaglutide has been shown to significantly reduce drinking, as well as studies that are starting to show in smaller samples that it reduces tobacco and it reduces opioid use disorder. These researchers are also starting to look into the electronic health records, and this is again one of those studies showing that individuals that have diabetes that were treated with semaglutide compared with individuals with diabetes treated with other drugs have a significantly reduced risk of overdose. So that data is very, very exciting because it does seem to show promise for the treatment of substance use disorder. The mechanisms are not understood, but that's why we do science. And again, this is an area that we want to encourage investigators and researchers. And during the presentation that I was given today, actually recognizing that the University of Buffalo substance use disorders research is one of the priority. Again, I want to urge the opportunity that we all have to evaluate the extent to which these medications can provide us with alternative treatments that are not going to be limited to alcohol or opioid like we currently have, or nicotine, but that can be used for the more and more frequent emergence of polysubstance use disorder in general, for whichever substance use disorder you have, or for polysubstance use disorder. So I end up my presentation with this slide, which actually shows to the left the delineation of what we have actually learned to understand what are the brain circuits that are affected by the chronic administration of drugs in people that become addicted. And it identifies not just one single system like the reward system, which is, of course, very relevant during the binge intoxication phase, which is sort of like involving multiple areas, not just the nucleus accumbens, but medial prefrontal cortical regions are fundamental, and that is responsible for initiating and sustaining drug taking. But that is also taken over by changes that happen in the neurocircuitry associated with negative affect that makes people very, very vulnerable to stress, depression, irritability, increasing the risk for drug taking as a means of escaping that state. And then, of course, the whole phase of preoccupation, anticipation, rumination that is fundamental for enabling self-regulation and control. And as we delineate what are the neurocircuits affected by addiction, then we can take advantage of all of the neuromodulation tools that are emerging, both for preclinical use and investigation, but also importantly for clinical use. And some of them are already approved for the FDA for the treatment of certain substance use disorder. And with that, I want to thank you for your attention, and I'm going to stop sharing.
Thank you, Dr. Volkow. I want to be considerate. First of all, the comments in the chat are overwhelming, and I've been trying to synthesize them all, but the biggest theme out of all of it was great talk, amazing. She's wonderful. So thank you for taking the time to do this. I'm conscious of your schedule. Do you have time for at least maybe 1 or 2 questions, or are you off to your next meeting?
No, I have time. And I apologize because I thought I was trying to limit it to 45 minutes, but I guess there was too much data, and I apologize.
No, please do not. Please do not. The enthusiasm for everything that you delivered was overwhelming. Everybody wants to know when they're going to have access to the recording so they can share with colleagues. So I think the first question is actually a really excellent one. We have strengths across the university. Obviously, Dr. Brashear mentioned in her remarks the commitment to addiction work in sciences. But we also have significant strengths in the aging space as well. We're very fortunate to have the full complement of health science schools, everything from strengths in social work to public health and dentistry and all across the board. So can you just comment or give your thoughts on how you think that drugs and social factors will affect aging brains while dementia risks increase? If you have any thoughts on that.
Oh, absolutely. Yes. How can I not have thoughts on that? Because it's very, very relevant. And I was telling that the number of people that are consuming cannabis 18 years or older is significantly increasing. But the population, the demographic, where you see the fastest increases, not in total absolute numbers, but if you just look at the rate of increase, are the elderly people, people that are 65 years or older. And this, in a way, is likely to reflect the fact that as you grow older, the risk of having pain is much greater, as well as other ailments. And cannabis is being used, among other things, as an analgesic drug. So it is important, and in my brain, it's crucial because people are using it, whether the evidence is there or not, though there is some evidence that it can have analgesic effects. I think that whether it is the panacea, that's a different story as an analgesic, because like with opioids, you become tolerant, and intoxication with cannabis can actually make you a little bit blunted. But overall, there is not two ways around it that people are using it for analgesia. So understanding how exposure to cannabis in elderly people, what does it do to the brain? Could it increase the risk of dementia, or could it be neuroprotective? I mean, cannabis has anti-inflammatory effects. So if it has anti-inflammatory effect, that could be a positive. But on the other hand, stimulating cannabinoid systems basically blunts the brain. I mean, it actually attenuates excessive stimulation. It attenuates excessive inhibition. And you need your brain to keep active in order to basically maintain the synapses. Otherwise, it starts to atrophy. So I don't know. I really literally don't know. And I've been sort of actually highlighting this as an area that we should be looking in. And there's some intriguing data that actually is in a preprint, or it may have come out, but from Enigma, the big database from the UK, that actually indicated that elderly people consuming marijuana had better measures of cognition and brain health than those that did not. So it's a question that we owe it to the public to actually address. That's one. In another area that I think, I mean, obviously there's been a lot of work with alcohol, and the notion that alcohol use accelerates the effects of aging. And we have looked into that, and yes, the amount of cortical atrophy, ventricular enlargement, and reduction in volumes is accelerated in people that are drinking. But what about opioid use disorder? And this is an area that we have focused basically most of the research on overdose and mortality, but we have not gone back and says, well, what happens really with the people that have multiple overdoses that don't die? it must not be very good for your brain to become hypoxic. So when you have an overdose, you lose consciousness because there's not enough oxygen. Well, what happens if you have repeated insults? And to what extent that, for example, could increase the risk that someone actually increasing the risk for dementia? And I think this is a crucial question. And it's also relevant, not just in terms of the light of the opioid use disorder, but if you are a patient taking high doses of pain medication or with opioids, that's going to produce respiratory depression. And when you sleep, which basically brings down your respiration frequency, could you actually that increase your risk again for hypoxemia and dementia? I do not know, but extremely important. So if you have researchers out there at the University of Buffalo, have them look into this because it will be very valuable.
Well, thank you for that. And we will be sharing all the nuggets that you had in your talk today. Another question, and it seems logical because I'm trying to synthesize this, so I'll do the best that I can. So many people on the call are participants and leaders in the educational process at the university and at other locations. And for an example, we have a very accomplished clinician who's actually been very generous in funding some seed funding to look at how to introduce practitioners and clinicians to pain management and in that space. So there was something by Dr. Sanjay Gupta that came up in the chats and everything like that. So I think people are wondering what you think are the tidbits and the things that you see as fostering the next generation in this space. And I would just ask that you think about it not from the perspective of just medicine, but again, because we have the full complement of health science schools. What would encourage people to do good research in this space, and what do you think it needs to look like?
Well, I mean, pain is a very neglected field in medicine. We have been for many years investing on research that aims to actually understand the neurotransmitters that are engaged in modulating pain perception. And NINDS have been investigating more on the development of therapeutics that are not necessarily just basically linked with the brain process. And we are the two institutes that have invested the most amount of money. But then in 2016, Congress gave us, as part of the HEAL initiative, which was basically trying to give dollars to do research to address the overdose crisis, which was born out of the lack of alternative treatments that led to the overprescription of opioids. So that gave us a big infusion of money. Initially, the first year for doing research on pain was 250 million, and that has increased since then. So I think right now it may be 290 million extra dollars that went to NINDS to be able to address the need for developing many needs, from the notion of safer and more effective analgesics to actually investigating the efficacy of interventions like acupuncture or holistic therapies that can improve the outcomes of individuals. So I would urge you, if you are all not familiar with that you look at the website for the HEAL initiative to identify the different areas of interest that the NIH is looking towards funding. There are many opportunities, and I think I brought up the whole issue of psychedelics because that is, for example, an example of a pharmacological agent that for which there is evidence again that it could be beneficial for certain types of pain conditions. And again, it deserves investigation. The same thing with the GLP. And this was something that actually, if you ask the AI of Google to tell you what do we know about GLP and pain, it helps you identify 4 or 5 pain conditions where actually there is some evidence that it could be beneficial. Again, the mechanism could be, on the one hand, directly related to its neuroinflammatory properties. Of course, another one would be that as you reduce the weight, you're going by default reduce the risk of having joint diseases that produce pain. So it is an area that actually opens again new vistas on the way that we are treating pain and or substance use disorder.
Thank you so much. Do you have time for one last question?
Yes.
Okay, I'll be quick about it. This is relevant, especially to the program that Dr. Brashear mentioned that Dr. Lynch has been leading, the Matters program that's originated out of the University of Buffalo. Is how do you envision that your agency or others can really stay on top of the ever-changing landscape of drug supply? Because it's constantly evolving, and so how do you be proactive about it rather than reactive?
Yeah, and first of all, in order to address it, we need to work closely with other agencies because, of course, CDC is the agency that does the surveillance. What we do from the perspective of research is develop the tools that can help us identify, and then once they are identified, new substances to characterize them so that we understand them better. So a perfect example is NIDA. More than, I think it was in 2018, we launched a project actually through our SBIR program for wastewater to actually develop and expand the use of wastewater for the documentation of the exposure to drugs in a given community. And that gives you, so in that instance, our initial studies were trying to understand what was the prevalence and the frequency and how much did it change fentanyl content in the wastewater, methamphetamine, cocaine. But you can also use that wastewater to identify substances that actually are new emerging ones that are not the one that you are looking for. And for that, we've also developed tools, instruments that are accessible because the instruments exist, but you actually are limited to certain laboratories. So how do we have promoted research, again, through our SBIR and STTR program for handheld devices that can actually help identify them, and for models where you obtain the information in the place of the wastewater and then send the characteristic signal to a laboratory then that acts like a hub to identify the new substance. So these are some of the examples of how we are using technologies and tools to help identify the constant changing landscape from two perspectives. One of them, new substances are emerging, new synthetic substances, and this is a worldwide phenomena. But then the other one, we're seeing more and more combinations. Drugs, anti-epileptic drugs mixed with actually substances of like opioids or cocaine. The one that has generated a lot of interest is, of course, the mixtures of psilocin with fentanyl and heroin. So, but they are constantly changing, and being able to address it and understand and investigate. So also research on how do we treat them? How do you treat an overdose when you have someone with psilocin and fentanyl, or you have someone with fentanyl and a synthetic benzodiazepine, a new synthetic benzodiazepine, or a new synthetic cannabinoid, which also enhances respiratory depression, and it makes reversal much harder. So all of these are areas of research that we're very interested on funding.
Thank you. That's really interesting to know, because we actually have a group in biochemistry that was doing a lot of wastewater testing during COVID, and really helped us be responsive across our community. So it's interesting to know that you can do it in a similar fashion. But thank you so much for the generosity of agreeing to do this and taking so much time with us and sharing with us. It's a big opportunity for us to have an NIH director join us and share your thoughts about your agency and the work in your space. And as Dr. Brashear mentioned, my gosh, your accomplishments as a researcher, they speak for themselves. So it's beyond impressive. But thank you very, very much on behalf of UB and all of the health sciences and everybody from even outside the community that joined us today.